Okay, so I think we can start as in the introduction and then we can move ahead, right?
Yes. I think that would
Okay.
be better. Okay. So, very good morning, good afternoon, and good evening to all the junior doctors from different parts of the world. I'm Dr. Venkatesh Karthikeyan from India, and I co-chair the NCD working group of the World Medical Association Junior Doctors Network. We are here for the World Diabetes Day webinar on the topic Diabetes in Primary Healthcare, jointly organized by the NCD working group and the Primary Healthcare working group of the WMA JDN. As we all know, 14th November is observed as the World Diabetes Day every year. Diabetes can impact people across all the life stages, including childhood, reproductive years, working age, and other adulthood and older adulthood. The theme of this year's WHO World Diabetes Day is diabetes across life stages, which recognizes that every person living with diabetes should have access to integrated care, supportive environments, and policies that promote health, dignity, and self management. This campaign emphasized the importance of a life course approach to diabetes prevention, management, and overall well being. WMHADN is proud to take part in this important global campaign. We have around 90 registrations from 20 different countries, which shows the importance of this topic. We are expecting few more to join this session, but without wasting time, we will start the session. We have also with us the brain behind the formation of the WMA NCD working group, a supportive force, and the chair of WMA JDN, Dr. Pablo Estrella. I request Dr. Pablo to please welcome the participants.
Thank you so much, Dr. Venkatesh. It's a real pleasure to be here. Sorry that I cannot turn on the camera as I'm on the go. But I'm Dr. Pablo Estrella. I'm a medical doctor from Ecuador and a specialist in public health. And especially this year that we had the United Nations high-level meeting on non-communicable disease. The diabetes topic is such an important topic because it goes across so many points from primary healthcare, vaccination, prevention, and so many other topics. So it's a great opportunity now that we're celebrating also the World Diabetes Day, that we have finally our NCD's working group in the JDN. And especially I'm really thankful also for Venkatesh and all the team that have prepared this webinar, but also our esteemed speaker. So without any further ado, I give you back the floor, Dr. Venkatesh. Thank you so much.
Thank you so much, Dr. Pablo, for always supporting our activities. So next, I would like to introduce the speaker for the day, Dr. Prajjwal Pyakurel. With over a decade of experience in public health and epidemiology, he is currently a postdoctoral researcher at Boston University, at Boston, USA. His work currently focuses on understanding the sociology of type 2 diabetes mellitus in Nepal, integrating comparative data from Mauritius, Pakistan, and India. His expertise spans epidemiology, public health, and biostatistics with a strong commitment to advancing to an understanding of health challenges in underserved communities. He is currently the co-chair of the NCD working group of the World Federation of Public Health Association, Geneva. We are very much privileged to have you as a speaker. Over to you, Dr. Prajwal.
Thank you, Dr. Venkatesh, for this wonderful welcome. So today I'll be discussing about the sociology of type 2 diabetes context, which we are designing, in especially in the low income country setup. So can I share my slide? Yeah.
Sure, please.
So it will be easy for me. Okay. So shall I need to turn on the camera?
Upon your convenience.
Okay. Okay. Today, I'm going to discuss about the sociology of type 2 diabetes in the context of 5 to 35 vision and ICEHALL conduct. So myself, Dr. Prajjwal Pyakurel, I am MD in community medicine. I did my MD and MBBS and MD from BP Koila Institute of Health Sciences, Dharan, Nepal. And currently, I am the Associate Medical Director of this 5 to 35 Global Foundation for Community Health, where we envision to enroll, launch this diabetes prevention program all around the world in coming decades or so. So currently, I'm working as an NIS 232 Research Fellow in the Department of Neurology at Mass General Hospital, Harvard Medical School, Boston, USA. So before going to the topics, so diabetes is very prevalent all around the globe. It's not a one country problem. It is a global problem. Every second house in every part of the world, people are suffering from diabetes these days. So it's all about not just about treatment and management, but about prevention. So our study, this sociology of type 2 diabetes mellitus, which we are currently undertaking, will address those issues in the longer run. So understanding the diabetes sociology, you have to understand what is diabetes sociology. So this study we are planning to launch in 4 countries, the Mauritius being the primary country, and Nepal, India, and Pakistan are 3 other extension countries where this project is going to be launched. So type 2 diabetes affects nearly 40% of Mauritian adults. This is not about Mauritius only, it affects in every part of the world, in India, Nepal, Pakistan, diabetes has affected a lot of people. It is a crisis beyond medicine. So where the challenges in health or healthcare cannot be solved by medical science or technology alone, Yes, diabetes. There are a lot of drugs has been discovered. There are various trials which have been conducted, but we have to understand the sociology of type 2 diabetes, especially in low middle income countries setup. This is very important. So it is the problem lie in the social factors, the economic factors, cultural factors, political factors, and we need to address those things in order to solve the problem of diabetes. And it is not only the biological or clinical care. So there is always a linkage of diabetes with the social determinants of health, poverty, discriminations, environment, culture, or policy, not just pathogens or genes. So we have to address those things if we have to solve the problem of diabetes in the longer run. I just want to give you the example, type 2 diabetes is not just about blood sugar and insulin, but also about food access, work stress, cultural eating pattern, and inequality. We have to address these issues if we have to solve the problem of diabetes. So what does this 5 to 35 vision means? The 5 to 35 vision recognizes that disease management begins with meaning, with how people perceive, cope up, and with prioritize their illness within the context of their daily lives. That's very important. Okay. So this study asks, what does it mean to live with diabetes in Mauritius, and by extension, the same question for our sites in Pakistan, India, and Nepal. So what we are trying to do is this study is looking beyond medicine, and health and illness are not just biological experiences. It is a social experience as well. So it's about understanding how diabetes become part of people's identities, relationship, and everyday choices. So how we are going to cope through family support, religion, traditional medicine, or self-care. This will be addressed through this sociology of type 2 diabetes projects. So in this project, the core heart is the CHO and the CSC. CHO is a community health officer who are a medical trained doctor or a medical trained nursing professionals who will be working at the community level to prevent diabetes. And CSC is the community health committee, and the committee represents committee members, ensuring that their voices are heard, their priorities are addressed. So this will be our members who are very positive about their community and want to develop that community. So we will be forming the CHO and CHE, which is the heart of this project. So our approach will be, qualitative semi-structured interview. So we are planning to conduct different, qualitative semi-structured interviews in 4 countries, Nepal, India, Pakistan, and Mauritius. And we have already completed the, the qualitative semi-structured interviews of Mauritius. And our lens will be, the interpretative sociology plus symbolic interactionism. These are the two common terms used in the philosophy of public health sociology. So we have to understand what is this interpretative sociology and symbolic interactionism. So basically, interpretative sociology is an approach that focuses on understanding the social life from the perspective of people being studied rather than explaining behavior purely in terms of external force. So we have to understand the human behavior, how it works, in different country contexts, how it works in India, how it works in Pakistan, how it works in Nepal, and how it works in Mauritius. So we have to dive into at the community level and understand the sociology of human behavior regarding the diabetes. There is another term called symbolic interactionism. So it focuses on how people create and share meaningful daily interactions. Okay. So for example, a person with diabetes may see insulin not only as medicine, but as a symbol of dependence or failure, shaped by by what others in the community believe. So it means that the illness and care are not only biological experience, but also the social and symbolic ones. So symbolic interactionism is another term which will be used in this particular study. So what we are trying to do is we are trying to capture life experiences, coping behavior, and readiness for reform at the community level. And this is anchored in the philosophy of seed scale, philosophy, empowering communities to own their own health transition. So what is seed scale philosophy? So seed scale philosophy is a community development approach that focuses on scaling of successful local initiative from the seed level. So we'll start from the ground level, grassroots level, at the community level, okay, and focusing on the local initiatives. What could be the local initiatives in context of India? What could be the local initiatives in context of Pakistan? What could be the local initiative in context of Nepal and Mauritius? So we have to find out what local interventions work on that particular setting to prevent diabetes. For that, we have to understand the sociology of type 2 diabetes. So we will be analyzing this data using Braun and Clock thematic framework using NVivo software, and where we will familiarize enough data. We'll generate initial codes and search for themes and we'll review the themes and defining and name the themes and produce the report. That is our strategy in this project. So regarding the Mauritius, we have already completed 24 interviews, all transcribed, cleaning, editing underway. And thematic coding, the initial thematic coding has signaled the need of community health officer curriculum. So this is the need, in every country, especially where these entities are prevalent in diabetes, hypertension are prevalent. We have to develop the community health officer, where the medical doctors or public health professional or nursing professional have to go to the community and work for the prevention of diabetes at the community level. So we are trying to design this CHO curriculum in different country contexts. So we have planned to draft manuscript, targeted for January 2026, and hopefully it will come out, and I'll share with Dr. Venkatesh, and he can share with your team as well. So what are the key emerging themes which has originated when we, transcribe this Mauritius study, So the first theme which has come out, is normalization. Diabetes seen as a part of aging, urgently diluted by familiarity. So what does it mean, So people in the community think diabetes is just not a normal part of getting older, and they may not see it as an urgent or serious and might delay treatment or lifestyle changes. So it is a concept used in public health sociology to describe how common experiences or condition can lose their sense of urgency. So people think that diabetes is a normal, it's a part of aging, but it is not so. We have to understand the sociology of type 2 diabetes for its prevention. So another part is the gender care. Women sustain adherence through the informal family support. So what does it mean? So caregivers' role are influenced by gender. So women are playing a key role in helping patients follow their treatment or care plans in the community, in the household setup. So in our household also, if my father is suffering from diabetes, if my mother is suffering from, if my brother is suffering from diabetes, my mother used to push, have you taken the medicine or not? I have prepared you the healthy meals. So in that way, women are influencing the prevention of diabetes at the household level also. So women often acts as a backbone of care within families, which help maintain adherence to health routines. So that is very important. So this themes has emerged from the Mauritius study. Another part is system trust, respect for public health services, yet frustration with overloaded. So what does it mean? So people trust and respect the public health system. They value its role and recognizes the essential service they provide. However, there's also frustration because the system is overloaded. long waiting times is there. There are shortage of staff in different health centers and limited attention from health workers. So this has also affected the management of type 2 diabetes in different country contexts. And there is another term called cultural mediations, So pharmacists and faith leaders shape behavior more than the clinicians. So they are the trusted intermediaries in the community, and they are shaped within the social and cultural network, suggesting that effective intervention may need to engage these local influencers alongside clinicians. So we cannot skip those people, pharmacists, faith leaders. So if I'm sick, I go to my pharmacy and take my medicine. They will suggest something and I'll take that medicine. So intervention is needed at the pharmacy and the faith leaders level as well. And readiness for ICEHALL, so strong willingness to accept CHO if community embedded and locally trained, So if somebody is locally trained, for example, if somebody is working in Indian context and if they are locally trained and they will understand their problem more than those who are working in Nepal or Mauritius or Pakistan, So understanding the local context is very important, and that is the philosophy of ICEHALL. So progress update regarding Nepal, Pakistan, and India. So in Nepal, we are in the process of ethical submission, and there is a site called Saraswati Nagar, which I have developed during my stay in Nepal, a site in Kathmandu, Nepal, called a place called Saraswati Nagar, where we are trying to develop a surveillance site for the health prevention promotion of NCD activities. So I'll discuss more about this in my presentation. So Pakistan, we have identified local physician and young leaders identified. Sociological model training is ongoing. And in Indian side, confirmed and preparation phase for qualitative capacity building is ongoing in Indian context. So what we are trying to do is, we are trying to see, and we are trying to share coding and develop analytical framework across all 4 countries. So ensuring comparability and cultural depth. So, we will analyze all the countries' data together, and see what are the common things, what are the things which we have common, so that we can develop a joint intervention as well. So now I'll briefly talk about Nepalese context where I belong from, So how it has worked in the Nepalese context for the diabetes prevention and NCD prevention. So, in the context of Nepal, the government of Nepal released this annual health report every year, and the death due to NCDs have increased from 51% in 2010 to 71% in 2019. Prevalence of this, there is a step survey done by WHO country office Nepal as well in coordination with government. So prevalence of raised blood pressure and raised blood sugar is 24.5% and 5.8% respectively. So, and it is in increasing trend. And chronic obstructive pulmonary disease is 9.8% of the total death, So NCD's burden has been rising in our part of the world as well. So we can see, the cardiovascular disease is around 71% mortality due to cardiovascular diseases. And Delhi is, around, it has increased drastically for diabetes. You can see at number 10, diabetes percentage change has increased drastically in last 10 years or so. So there are different models of, NCD preventions, which the government of Nepal has launched in context of Nepal, So this is the people-centered NCD care model, which is launched by WHO country office Nepal. So the concept of this model is that there is a tripartite agreement between medical academic institution, provincial district health authorities, and NCD Department of Ministries of Health. So there is a tripartite agreement between academic universities. So in the context of Nepal, there are few academic universities which have been more working on this model, and there are provincial district health authorities whom academic institutes collaborate and work together, and there are NCD Department of Ministry of Health at the central level which coordinate or facilitate to conduct these activities. And this was another big project, which Nepal got, the train model. This is funded by NHLBI, National Heart, Lung, and Blood Institute, USA. So I was also the part of this project, and I was a co-investigator in this project as well, So the purpose of train was to build in-country capacity through the creation of transdisciplinary investigation team, to conduct large-scale research in low-income countries through skill development program, need assessment, and capacity building. So in this project, we did a lot of training program from the US context. We did a global health implementation science research, economic analysis, and global health policy making. Different courses we did and try to understand how it works in the US setup and how it could be replicated in the low middle income country setup. So after going through this all the campaign, I initiated my own initiative. This is NCD and mental health campaign in one of the urbanized community in central Nepal, and this site is based on for the sociology of type 2 diabetes studies. So the objectives of NCD and mental health campaign is to screen, diagnose, treat, primary healthcare, prevention, primary, secondary, tertiary, health awareness and advocacy, and community engagement, partnership and ownership, collaborations, national and international collaborations, local research, local solutions and local ownerships, people at a central point, and targeting through community, school, colleges, and workplaces. So the objectives of NCD and mental health campaign, which I am currently running, is this. So, I told initially also that the sociology of type 2 diabetes in context of Nepal will be done in this place called Saraswati Nagar, So this is the map of Saraswati Nagar, and we want to develop this as a demographic surveillance site where we can conduct a lot of research on NCDs preventions, health promotion and prevention, So there are around 25,000 to 30,000 population in this particular community, and we want to create a model, for NCD prevention and replicate in different parts of the country as well as in other parts of the world as well. So this is our vision, long-term vision for ICEHALL public health sociology study. So these are the different activities which we conduct, and at the community level, So, and every Saturday we used to organize different programs on NCD and mental health campaign prevention. We involve community, and the female community health volunteers and all the health workers and the community people come together and we discuss, we conduct rallies, These are all the activities which we used to do. And a lot of people used to come in our program. We used to screen for them for diabetes, hypertension, and start, intervention programs, and you can see from these pictures, all the local leaders are very much supportive about these initiatives, and this is the commitment which I used to do, to people, that you should not smoke, you should not drink alcohol, and you should eat healthy diets. Okay, so these are the initiatives which we used to do at the community level. So we are targeting this through community level, and we are going at the grassroots level and infiltrating at the grassroots level. So we also used to do the house-to-house visit program and work with the women's group, and we used to conduct walk program, and we used to do this physical activities, yogas and all, and in this way we are trying to make people healthy at the community level. So another part is targeting schools and colleges. Because the prevalence, when I went to the schools, the prevalence of smoking is very high. The prevalence of alcohol drinking is very high among youth students as well. So we have to intervene at this level as well. So we are targeting schools and colleges and organizing different programs in coordination with different, Lions Club and Rotary Club Internationals. We conduct this program at the community level. And another thing is the workplaces. So in the workplaces, especially at the banking sector, the life of people are very sedentary. So what we did in this particular site is we called all the bank managers in that community, and we interacted with them, and how we can make the lifestyle of bank people healthy, and we discussed and we conduct, various activities, and through the CSR funds of the banks as well, So we conduct rally, awareness session, advocacy sessions, and few research activities as well. So the heart of this project, I told you initially, is this, 5 to 35 community block, CHO is a community health committee, and CHO is the community health officer. So this one CHO is responsible to see after 1,000 citizens, and this CSC will be formed in the local community, and the CSC will be elected or selected from the targeted group of citizens on a rotating basis. So for example, there are local committees, at the community level. So we are targeting to make committees from them because they understand their community very well, and we want to create a trust triangle between this citizens, CSC committee, and community health officer in order to make the people healthy for the prevention of diabetes. So we have various supporting stakeholder at local level. In context of Nepal, there is a Toll Sudhar Samiti. That is a grassroots level organization. Of the government. There are local officials who are very much supportive. There is a ward officials. They provide us some fundings for buying this blood sugar machines, blood pressure machines, and there are municipal office. Municipalities, Kathmandu Metropolitan City Office. They are also very much positive about these initiatives at the community level. So we have very much supporting stakeholders. And we have a support of also of federal officials, So I was discussing this with Minister of Health and Populations, 4 to 5 months back in Nepal, And we are discussing how this could be incorporated at the community level. And he was also very much positive about our initiatives. So I told you, our philosophy is based on C scale, a highly effective social developmental theory. So where content experts, officials, and community come together and decide. Rather than in the traditional top-down approach model where content experts will develop the things, officials will execute those things, and community will be recipient of those things. But in this model, we are trying to work with the community together and develop a model. So intervention framework for ICEHALL project in context of Nepal. So this is the map of Kathmandu metropolitan city, this is the ward number 6. And we are intervening at this site, this site we are intervening at the community level. And this ward number 16 will be our control ward number 16 and ward number 22 will be our control site. So this is the design of ICEHALL, ICEHALL project. This is a big random cluster randomized control trial, which we are going to launch in context of these 4 countries. And it begins with the sociology of type 2 diabetes. So we have 5 interventions, basically, we will develop clinical management algorithms, and we will engage community engagement and do the capacity building. There is a bench grant map program where we will train a layman, on mental health counseling, and frugally innovative digital technology serving intervention models. So digital interventions, new technology will be incorporated, and public-private partnership will also be done. And we are in the concept of social entrepreneurship as well. So these are the 5 major interventions of ICEHALL clinical design. So I told you that this 10,000 population will be our intervention arm, and 10,000 population will be cluster control arm in 4 different countries. So 20,000 population in each country is our vision. And so, in part A, what we'll do is we'll do training, protocol development, infrastructure development, IRB approval, informed consent. And in part B, we'll intervention set of 3 months. So we'll do health survey, lab testing, and we'll start applying the interventions. So this is our visions for our ICEHALL project. So this ICEHALL is based on 3 pillars. There are 3 pillars: clinical excellence, community engagement, and research and training. So these are our 3 pillars of ICEHALL. So in clinical excellence, professional competency and passion for clinical medicine. So I always believe that we are a community medicine doctors, and community medicine public health doctors should have some skills of clinical medicine as well. So we have to show our skills at the community level for this. And community engagement and mutual understanding and respect and understanding and pragmatism and frugal innovation, what we can do at the community level. So this is another pillar of 5 to 35 vision. And another third component is research and training, where we'll be where we'll publish the papers, write do different sort of research training, ethical trainings, and try to build a team in different country context. So regarding the control side, I told you initially that this ward number 16 will be our control side, and ward number 22 will also be our control side, where we will try to see, how intervention works at the community level. So this is the metropolitan, this is the ward office of ward number 16, where we have gone with we've gone and talked with them, and they are very much positive about our initiatives. So NCD Nepal is in rising trend, and 71% mortality due to NCD, and Ministry of Health and Population, Government of Nepal has declared the Nepali calendar month Fagun, that is February-March 2025, as an NCD screening month. And so we have also proposed to the government to take this site as a demographic surveillance site, and during our meeting with health ministers of the government of Nepal. So we have been trying a lot, for NCD prevention, especially at the community level. So we have also developed a budget, how we are going to do this. There's a Nepal Society of Community Medicine. This is a professional body of community medicine doctors in Nepal. And we have to go through this, all the, this government processes, that is Social Welfare Council and Nepal Research Council, where we have to submit for our ethical and our funding these details. We have to submit, and then only we can launch this project in context of Nepal. So this is my experiences working for diabetes prevention since the last 10 years or so. So we screen a lot of people at the community level, and especially in the industrial setup, where we used to do a lab testing and apply different form of intervention at the community level. And we have few publications in our hand as well. So we have a pretty good experience to launch this project in different country context. So why it matters for ICEHALL? ICEHALL is very important. ICEHALL success depends on the trust, habit, and cultural fit, not just protocol fidelity. So it's not about protocol, it's not only about science, You have to go to the community. You have to understand the people behavior, human behavior, psychology in order to prevent diabetes. Sociological insight, refining messages, CHO training, and community engagement is very much critical for this project. The sociology arm is the ethical compass of 520 to 35. So it's just not about clinical medicine or a public health interventions, but it is about the sociological arm as well. So sociological arm is the ethical compass of 5 to 35 vision. So our roadmap in the coming years or so is, so what we are planning is the Mauritius paper submission and cross-country harmonization of interview guides. And in mid-2026, we are trying to complete data collection in Nepal, Pakistan, and India. And in late 2026, we'll publish cross-country comparative synthesis papers, and 2027, we will release 5 to 25 sociological white paper when society health itself, So this is our vision for this ICEHALL 5 to 35. So my closing reflection is health is a social behavior before it is medical, So it is not always about medical. We cannot, we have to prevent these entities. Otherwise, it's going to be a disaster in coming 10 years or so. It cannot be managed only by, it does not have only a medical solutions. There should be a preventive solution for diabetes as well. And we need a transformative health system model to prevent diabetes at different country context. The sociology of diabetes anchors ICEHALL in empathy, context, and meaning. And by listening first, 5 to 35 ensures that reform is not important. It is authored by the community itself. So what I mean to say over here is health isn't just about the absence of disease or biological dysfunction. Social factors like community, economic status, culture, environment, and social network also influences these behaviors. So ICEHALL behavior is community-centric, intervention is relevant, and culturally sensitive and effective. So this is all about my presentations. If you have any questions, I'm ready to answer. Thank you very much. Dr. Venkatesh, over to you.
Thank you so much, sir. It was a wonderful and insightful session. Usually, what we expect when we call someone for a webinar is that they will talk more about the concept and theoretical aspect. But it is we are very privileged to listen from you. You have discussed all the works you have done. You have given a gist of the works you have done in the diabetes in the primary healthcare, which is very inspiring, especially as a community physician. It's very inspiring for me and our target audience. And it is like wonderful to see the magnitude of work which you have done. All this we have just read in research papers during our journal clubs, and we are seeing it that you have done such great works. So we believe that this will be a starting point for our collaboration, and we'll be looking forward to do works under your mentorship in our NCD as well as the primary healthcare working group. Thank you so much, sir.
So Dr. Venkatesh, what I think is we are ready for collaborations with your team as well. So we have a big team over there in Nepal as well. And Dr. Dipesh, I believe, is over here with the president of Nepal Society of Community Medicine as well. So we are very open to the collaboration with your team as well. So let's discuss how we can do it in our another meeting as well.
Definitely, sir. And I take this opportunity since the participants are from our working groups majorly. I think if participants have any idea how to take forward this collaboration, is like, is there something which is work is done by our speaker? Can we be part of it? How we can take this forward? If you have any ideas, please unmute and ask. Or if you have any queries regarding what was discussed in the past 40 minutes, you may please unmute and ask. Yes, Dr. Samira. Dr. Samira, you're not audible.
Yes, I'm so sorry about that. Am I audible now?
Yes, yes, yes.
Okay, thank you for giving me the floor. My name is Samira. I'm a recently graduated doctor from Egypt. And first of all, I would like to thank you for this talk. It was very interesting, to be honest, to see the intersection between sociology and medicine. And I do see a potential collaboration or something that could be done is sharing the best practices or the most effective interventions that could be applied maybe at the level of primary care or GP clinics, or even within clinics in general for diabetes care and also prevention. So basically actionable interventions that doctors can directly use and implement, that kind of drive from your research and from the behavioral aspect as well. And maybe we could publish these findings in a toolkit that's easily usable by doctors, junior doctors, and any doctor working in internal medicine and primary care in general to implement in their practice. Thank you so much.
Thank you, Samira. I just show in my slide that, we will publish these papers, so the data is on the way, it is coming, and we are trying to analyze those data, and we'll definitely share with your team when it is published. Thank you very much.
Thank you.
Thank you so much, Dr. Samira. Any other queries we have? Because what I was having in my mind when we started this non-communicable disease working group is that one activity which could potentially done is some kind of a multi-country perspective from a junior doctor's viewpoint. As I have told in the introduction, we have around 130. We have members from around 130 countries. So if we could kind of collect the perspectives of junior doctors in diabetes care or NCD care, or something like that in a qualitative study, may preferably if we could plan something like that, it will be much more feasible, is a thought in my mind when we were starting this working group. I think so you may guide us if how can we proceed in this direction from the research front.
Yeah, and definitely, Dr. Venkatesh. I will share my experiences, what I did for this ICEHALL in context of Nepal, and I have a lot of practical experiences when I work at the community level. So I can share with your team. So let's plan another meeting, and discuss about how we go. And our team from Nepal will also join for that meeting. I'll discuss with my team over there, and they will join. And let's see, because this NCD prevention is not a single entity. We need a lot of teamwork and multifactorial things we should address in order to prevent NCDs especially at the community level. We have to hit the grassroots level. That's my vision. Otherwise, it's not going to work. And how we are going to translate the community related work at the policy level. So that should be our idea. So we can discuss on these things and see, and another thing is what we are trying to do in this project is we are trying to develop a clinical algorithm guidelines. For example, so if somebody had a heart attack at the community, so how we can take them to how we can manage at the community level before taking them to hospital. So there are golden hours. So what I'm advocating these days is aspirin should be provided to the people at the community level. So they carry the aspirin in their pocket if they are at high risk of cardiovascular diseases, although it is not given, not written in any standard guidelines. But we have to think from that perspective, innovations, how we can save the life of people at the community level if they have a heart attack. So because especially in low income country setup, we understand that it is very difficult when it takes around 4 to 5 hours to go to the hospital, and the patient will die on the way. So we have to know how to prevent those things, especially at the community level.
Very rightly said, sir. Just for your information, our WMA JDN is participating in the World Health Assembly every year, and we also assist in drafting the statements on behalf of WMA. For example, last year we drafted a statement related to NCDs, that we should spend more. We should increase the spending in training the health workforce with regards to non-communicable diseases. So these kind of advocacy efforts are being done by WMA and WMA JDN, being an international body. And I think when this power of advocacy is met by your grassroots level experience, just like the one you quoted, having some innovative approaches, having these drugs to be used during golden hours, if these kind of innovative things jointly taken forward by our team, then we can definitely propose it at the World Health Assembly also, and we can take this at a bigger level. Thank you so much, sir, for sharing your ideas.
Yeah, thank you, Dr. Venkatesh. Thank you. It was very pleasure, talking with you all. So I hope to interact with you, your team again, and discuss with my team in Nepal, back home, Nepal as well, and let's plan a joint meeting, and then from there we can take it forward.
Definitely, sir. I think we don't have any further queries, right, from our participants? Okay. If not, can we please turn on the cameras for a group photo, and we'll conclude with that. Yeah. Whoever is possible, please turn on your cameras.
Everybody, please, everybody.
Okay. I'll just remove the spotlights. 1 second. Yes. Okay. So I think few more have not turned on the cameras. If possible, please turn on the cameras. Okay. So on count of three, I'm taking a photo. Ready? 3, 2, 1. Smile. Okay. One more photo, please. Just a second. Yeah. Ready? 3, 2, 1. Smile. Great. Thank you. Thank you so much, everyone. We'll keep updated with our future engagements, and we also look forward to working with Dr. Prajjwal closely in the future. Thank you so much. We are closing the session now.
Thank you. Bye-bye.